Yep, time for another Puscast. For you new listeners, that guitar is by my son from, probably 10, 15 years ago. He's gotten much better. This is another Puscast covering the first 2 weeks of August 2016, and a little later than usual, as I was on vacation last week in Boston and the land of corn sweat, Minnesota. It's nice to be outside on the front porch doing this Puscast, although you may hear some occasional extraneous noise because I'm not sitting inside on such a beautiful day. Don't forget to go to my multimedia empire at edgydoc.com, where you will find links to my apps, my books, my blogs, my podcasts, and the references to this particular Puscast. But enough, let's get on with the literature, shall we? In HIV serodiscordant couples, how often is HIV spread in patients on antiretroviral therapy? There's a great deal of work on this, and the answer, of course, is it depends. The risk if patients are completely suppressed is fairly low, but how about in the real world, especially a resource-poor real world like Africa? In that part of the world, it wasn't quite as good in reducing transmission between serodiscordant couples compared to other studies. In this particular study, they found that those who are on antiretroviral therapy had viral transmission of HIV decreased by 77%, which sounds good, but it was at a rate of 3.8 per 100 person years versus 5.6 per 100 person years in those not on antiretroviral therapy. So are serodiscordant couples safe from passing on HIV if they're on antiretroviral therapy? Well, probably, but it's not perfect, and condoms are probably still part of the protection package. And as long as we're on the topic of the real world, no, not the MTV show, how good is the HPV vaccine? Well, there was a recent systematic review of the last decade's worth of use of the vaccine, and it looks pretty darn good. They estimate that there's been 90% reduction of HPV 6, 11, 16, and 18 infections, a 90% decrease in genital warts, a 45% decrease in low-grade cervical anomalies, and 85% decrease in high-grade histologically proven cervical abnormalities. And that is too soon to see the benefit of a decrease in cervical cancer, which we will see down the pike. Most of the effects are in those who get the vaccine before being exposed to HPV, although, quote, catch-up, end quote, plans have been beneficial as well. Not as good as the mustard plans or even the pickle relish plans, but the ketchup plans do work. And despite some brouhaha, which occurs with every vaccine, go to Science-Based Medicine if you want to read more on that, there does not appear to be any long-term side effects attributable to the vaccine. About 1 in 6 Americans have a genital herpes infection, at least those between the ages of 14 and 49. And the vast majority have never been symptomatic. Should you screen for HSV in that population? And the answer by the U.S. Preventative Services Task Force this month is no, that you should not. As testing is not sensitive or specific enough and probably will cause too many false positives with subsequent harm, especially given that treatment is problematic as well, so that they conclude that screening probably would cause more harm than good in populations. I would presume any new partner was positive for herpes. Not that that's an issue at my age and marital status. Or am I oversharing again? What are the benefits of influenza vaccination and influenza treatment if you're pregnant? Well, they are there. If you are vaccinated, if you get flu, you are less likely to get severe flu. The more severe flu you have, the more early delivery and fetal loss you are likely to experience. And in this study, if you got medications to treat flu earlier, you are likely to have a decreased length of stay. That was the result of a study that looked at pregnant women, 865 of them, who developed laboratory-proven influenza during the 2010 through 2014 flu season. Of these women, 7% had severe influenza and 4 died. This is another study that shows benefit from treating influenza in pregnant women and benefit from the vaccine. It's not a 100% benefit, but the benefit is still there. It is, like I like to say, like wearing seat belts in a car accident. It's better to have a car accident with them on than without and decrease the odds of dying. They estimate, for example, during the great pandemic of 1918-1919 that about 1 in 10 women lost their children due to influenza. The p-values for benefit were not great in this study, 0.03, but it's part of a consistent literature that points the same way. Benefit of the vaccine and treatment in women who are pregnant. We still don't know about men who are pregnant. In a different study looking at the birth outcomes in the flu seasons from 2014 through 2015, found that women who had the flu vaccine decreased the risk of delivering a preterm infant, and they estimate that 1 in 5 preterm deliveries during flu season could be prevented by vaccination. So when I get pregnant this year, I'm getting the flu vaccine. It's safe, it will allow me to keep my baby, and it will probably prevent me from dying should I get flu anyway, from what is unfortunately not a perfect vaccine. Infectious diseases, as I have said many times before, is nothing if not the application of evolutionary principles. To understand ID, one has to understand evolution, and I'm not a big fan of evolution sometimes, like this particular case, norovirus. So there was the predominant norovirus in the world was GII.4. And this is the one that's been causing epidemics around the world, and it tends to change fairly rapidly. So in 2014, a new one, GII.17, emerged and has been causing big problems both in China and about the world. So they looked at the evolutionary history of this organism and found that it started in Africa around 2001, and it evolves at a very rapid clip at 5.6 times 10 to the minus 3 substitutions per site per year. The result is that over time, it altered until August 2013, and then it became quite virulent, causing extensive epidemics for a couple of years in China and other parts of the world. So that's just what we need, is a gastroenteritis organism that evolves rapidly, perhaps keeping ahead of the immune system, and that's been suggested in transplant patients as well. And then we get new emergence of new strains with regularity. And so that explains the more recent outbreaks of norovirus, all thanks to a little bit of evolution. For those regular listeners of this Puscast, and you do have my sympathies, have heard me go back and forth over the years as the studies have trickled in. What's best for treating VRE in the blood, daptomycin or linezolid? One study shows one, another study shows another. What we need is a meta-analysis. You know, the theory behind a meta-analysis, of course, is you take multiple piles of cow manure, you put it all together, and you're supposed to get gold. But this meta-analysis looked at that particular question and found no difference between daptomycin and linezolid in terms of safety or efficacy. But as is so often the case with meta-analyses, it's GIGO, garbage in, garbage out, and they note that the result should be, quote, interpreted cautiously because of the underlying nature of the studies put into the meta-analysis. It's why I sometimes wonder why we even bother with meta-analyses. And I tend to go along with Will Rogers, who wisely said he never meta-analysis he liked. What? You don't know who Will Rogers was? Google it. Kids today, I'll tell you. Ticks can carry more than one pathogen. Maybe a fifth or a fourth of ticks in the U.S. have more than one pathogen if you look at them, mostly in the American Northeast. How clinically relevant this is depends on who you ask. The Lyme literate world, he says with sarcastic quotes, would suggest it is a big problem. I'm not so certain that's the case in the non-Lyme literate world. This study out of the French Ardennes, so it's important to know this is in the French woodlands, not the United States, took 267 female ticks and looked at them for the presence of a wide variety of pathogens. And they indeed found a wide variety of pathogens, including Borrelia species, Acinetobacters, Wolbachias, and Babesias. At least half the ticks were infected, and 45% of ticks had more than one organism, and some carried up to 5 different organisms. Whether this is widely applicable to ticks in general or just to the ticks in the French Ardennes is a question to be answered. So it's safe to say that ticks can give you more than one infection. The last decade has seen syphilis become predominantly a disease of men who have sex with men. But there's more to it than that, as this study out of Houston, Texas shows, and it's consistent with other studies that have similar results. Not only is MSMs who have syphilis at rates about 30 times higher than heterosexual men, but it is men who get their partners via the internet and who have anonymous sex. Also, in Houston, it was more likely to be Hispanic men who have sex with men. But it's a typical pattern across the board for the development or the acquisition of syphilis in MSMs is those who get their partners on the internet and have sex with people they don't know. Maybe we should no longer talk about getting a virus off the web, but instead a spirochete. Oh, I might actually buy a program if it stopped the installation of spirochetes on my computer. And what should you do for patients with atrial fibrillation during sepsis? Probably leave it alone. In this study, they had an increased risk of bleeding, but they did not have a decrease in their thromboembolic events. So it doesn't help to give septic patients anticoagulation for their sepsis. And AFib is not an uncommon complication of multiple infections in the hospital, be it pneumonia or influenza, etc. So one wonders the benefit of giving these patients anticoagulation. And the other thing I keep harping on in this podcast is the subsequent risk of vascular events in patients who have infections. And here's another one. This study is called Longitudinal Study of the Effects of Bacteremia and Sepsis on 5-Year Risk of Cardiovascular Events. Quote, the causal odds of experiencing a CV event was 1.52-fold and 2.39-fold higher in patients with prior instances of bacteremia or sepsis, respectively, compared to those without. Prior instances of septic shock resulted in a 6.91 increase in the odds of a myocardial infarction. End of quote. I mean, whoa. Get infected, have a stroke. Get infected, have a PE. Get infected, have a myocardial infarction. It is a consistent pattern. And again, to date, I only know of one study that has looked at aspirin as a successful prophylaxis in vascular events after patients in pneumonia. Somebody needs to get cracking on a clinical trial to show that it shows more benefit than harm to treat patients after infections. We don't want to have a reproduction of that aforementioned atrial fib study, now do we? But somebody get to work on this. And just like that, I'm harping on another topic, which is the importance of fevers, or perhaps the importance of avoiding non-steroidals. There was an article years ago that looked at the results of pneumonia patients who got NSAIDs, and they were more likely to develop a lung abscess or an empyema. It's bad to blunt the inflammatory response. Inflammation is good. Now, this study out of France looked at the effect of NSAIDs without antibiotics in children with acute viral infections, and found that kids who got NSAIDs were more likely to have had an empyema as a complication of their viral infection. Probably they got a viral infection, they got NSAIDs, they got a secondary bacterial process that led to an empyema. But it's another in a series of articles to suggest that when patients have infections, you should not mess with the immune system by giving nonsteroidal anti-inflammatories. NSAIDs are bad, aspirin is bad, infections are bad. There's so much badness out there. But then aspirin is an NSAID. And do you want to be giving that to patients with infections to prevent their stroke? Interesting questions. Damned if you do, damned if you do. Stenotrophomonas multifida is one of those pain-in-the-neck organisms that has very few antibiotics to which it is susceptible. The usual drug of choice is TMP sulfa, and you and I both know what a pain TMP sulfa is. It seems like everybody and their mother is allergic. So what are you going to do? Well, this study looked retrospectively at a small number of patients, 23 in each group, of patients with Stenotrophomonas multifida who received either minocycline. Evidently, almost 99% of Stenotrophomonas multifida are susceptible to minocycline versus TMP sulfa, and found that the outcomes were the same. They gave 200 milligrams a day of the minocycline. So if you have a TMP sulfa allergic patient or resistant Stenotrophomonas multifida, it looks like minocycline is a good alternative. Plus, you'll get rid of their acne. So you have a patient with a prosthetic joint infection. The joint is debrided and they get a poly exchange. Then how long do you treat? Long time. This study, however, randomized patients to either 8 weeks of levofloxacin plus rifampin versus 3 to 6 months of levofloxacin plus rifampin. 3 months for hips, 6 months for knees, and found that the endpoint, which was cure rate, was about the same in all groups, about 50%. I don't know, not bad, I suppose. I think 50% cure rate seems a little under what I would expect. My inclination is to give them 6 weeks of IV plus rifampin, then a course of oral therapy plus rifampin. And there is one retrospective study that suggests, especially in patients with Staph aureus, that they be on chronic suppressive therapy. I recently had a patient who, after 2 years of chronic suppressive Bactrim, went off it at the advice of his doctor in outside hospital, and within 2 weeks was back in getting his knee removed as the staph had recurred. Sometimes there's the difference between therapy that is optimal and therapy you can get away with. I think I'm going to stick with my more long-term courses of antibiotics. One of my rules of thumb is that anybody who wears their OR scrubs to the grocery store after work or other places is a dick. And that's 100% sensitive in specific. I mention this only in that there is a new set of guidelines for proper attire for surgeons and other OR personnel, and they say, quote, change out of scrubs before leaving the hospital, end of quote. But really, who thinks it's cool after spending your day up to your armpits in another person's guts to walk out into the public wearing your scrubs? Only someone who goes by the diminutive of Richard. They also recommend that you do not let your masks dangle. I find that one amusing. As a fellow, I was called by the OR because a surgeon had worn her mask to the cafeteria and let it hang loose, and then during the case, a broccoli flowerette fell out and into the open heart. It's the biggest vegetation I have ever seen. True story, and disgusting, and why you should take your damn masks off when you leave the OR. But it's also my opinion that the vast majority of healthcare professionals don't really believe in germ theory, at least to judge from their actions. And we'll end on a cheery note. A study published out of the Daneland, the Netherlands, showed that patients who get infected are much more likely to have death by suicide in the upcoming year. They estimate that the incidence of suicide overall was 1.42 compared to people without infections, which is weird. Not only was hepatitis, HIV, or AIDS associated with suicide, that's not too surprising, but having a respiratory tract infection and sepsis also increased your risk for suicide, and it occurred whether or not you had a prior psych history or not. In patients with no prior history of a psychiatric diagnosis, having an infection increased the suicide risk 1.31-fold higher, which is remarkable. They speculate that maybe pro-inflammatory cytokines may somehow increase your risk for suicide. So I talked earlier about how your chance of dying of a vascular disease goes up after infection, and so evidently does your risk of suicide. I guess that's it. I thought this would be a longer podcast, but a lot of articles just were not all that interesting when I finally got around to reading them. So that ends the Puscast for the first 2 weeks of August 2016. References and links to my growing multimedia empire of books, podcasts, apps, and blogs can be found at edgydoc.com. And of course, it is your responsibility to go on iTunes and write me glowing reviews, even if you think this podcast stinks on ice. Otherwise, talk to you next time, and thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall follow along with you. Thank you. In dictation, and goodbye.